COVID-19 in Jamaica, and we ask our minister to make that update. Thank you very much, Stephen. Good evening, ladies and gentlemen. Good evening to my colleagues, the Permanent Secretary and the Chief Medical Officer. Today we will give our regular update, but after which, in keeping with a discussion which has been taking place from my sectoral presentation through to the Special Select Committee of Parliament, we will be looking at the spend on COVID to date. The taxpayers of Jamaica has put out significant resources to support the team in the field to control the spread of COVID. We think, again, in the interest of transparency, that we should explain that spend, and the Permanent Secretary, who is the accounting officer of the ministry, is going to take us briefly through that spend, after which we will identify a few other initiatives as it relates to the future of managing the COVID process. I did make mention of a number of those issues in my presentation. The fact is that as we lift restrictions, there are issues that will have to be confronted in terms of surveillance, in terms of managing the possibility of a greater risk profile, and there is a COVID plan that is being put together, and we will focus on some of the features of that, and then we'll take your questions. So let me move right into the updated details. The last 24 hours, we have seen Jamaica recording 2 new COVID-19 cases. That's 2 new COVID-19 cases, bringing the total number of confirmed positives for the island to 753. The new cases include 1 male and 1 female, age 44 and 55 years. In the case of in the first instance, that individual is a tourist who stayed in St. Ann and was subsequently repatriated. The other is a Jamaican citizen of a St. James address. There are now 235 imported cases, while 236 cases are contacts of confirmed cases. 39 are local transmission cases, not epidemiologically linked. 236 are related to the workplace cluster in St. Catherine, and 7 cases are under investigation. The majority of the confirmed cases are females. That would be 424, or 56%. And of course, the other numbers, 44% or 329, are males, and the range of persons affected from 2 months to 87 years. In terms of recovery, of the 753 cases confirmed with COVID-19 to date, 603 or 80% have recovered, while 19 or 2.5% have repatriated, and 10 or 1.3% have died. There are 121 or 16% active cases currently under observation. So 121 positive cases that are under observation. And there are currently no moderately or critically ill persons among the active cases. This is something that we are very happy for, because what that means is that while we do have positive cases, the risk to life, certainly as it relates to those persons impacted, is minimal at this time, because there's no moderate or critical illness related to a COVID case, and that is a good sign for us. The island's testing numbers are now up. We have had 27,531 tests, including the 753 positives and the 26,722 negatives, and 56 that are pending. We have had some issues, challenges around testing and testing results. That's something we can elaborate on later on. There are some changes coming that hopefully will alleviate that backlog, if you will, and we can speak to that issue later on. So in summary, the two additional cases, a Jamaican and a tourist, 80% recovery, still the case, and 1.3% deaths, and 121 or 16% active cases under observation, with just under 27,500, just over 27,500 tests that have been administered. So that's the update, the daily update, and we thank you for listening. At this time, I'm going to ask, in keeping with the COVID spend, I spoke in the sectoral presentation 2 days ago on Tuesday, and did indicate that the ministry was allocated $6 billion, 3.8 billion already spent on containment measures. We gave a breakdown of that spend in terms of the regional authorities, the infrastructure upgrade, testing kits, and the provision of medication through the National Health Fund. We feel that we have seen the results of that spend in terms of our ability to date to control the spread or to treat with those who are affected. But we also believe that it is worth expanding on. So I'm going to ask the Permanent Secretary now to just expand on that spend. And I think he's going to use a PowerPoint presentation. P.S.
Thank you, Minister, and good afternoon, everyone. Today I'm just going to briefly go through the spend or the expenditure for COVID-19 to as at July 6, 2020. Now, the expenditure for the year 1920, which is fiscal year 1920, was approximately $2 billion, having received $2.1 billion from the Ministry of Finance and the Public Service. At the end of that year, we had a surplus. That means that we did not spend approximately $63 million of the amount allocated in that year. For fiscal year 2021, we have received approximately $2.5 billion from the Ministry of Finance and the Public Service. And of that amount, we have spent $1.9 billion. Cumulatively, we have therefore received approximately $4.7 billion, and we have expended of that amount $3.9 billion, or approximately $4 billion on COVID expenditure. Now, the categories of expenditure are outlined there. The largest category of expenditure, of course, is the transfers that we have to our partner agencies, the regional health authorities, the University Hospital of the West Indies, for the implementation of activities relating to the mitigation of the spread of COVID-19. The other areas of interest in terms of spend are those amounts that we have spent for medical equipment, including PPEs and drugs. So in that amount, we have spent approximately $577 million on medical equipment and approximately $956 million on drugs and other sundries. The other area of interest is what we have spent on accommodation, to include those costs incurred by the government in our quarantine and isolation activities for COVID, to which we have spent approximately $500 million. So overall, we have expended $3.9 billion again on COVID-19, with a balance of approximately $702 million to be expended in the month of July. So that gives us approximately 82% of the total expenditure that has been expended for COVID-19. But we have some results. I want to draw your attention to the fact that we are still in the epidemic phase of the COVID-19 pandemic. our response plan, as you recall, has 4 phases: the interpandemic phase, the alert phase, the epidemic phase, and of course the recovery phase. But we are still in the epidemic phase, and we have seen where during the epidemic phase we have had some, as outlined by the minister, we have 10 deaths with a mortality rate that is very well compared to what we are seeing internationally. We have the fact that we have 751 cases and about approximately 124 cases as at July 6. Our recovery rate is now 80%. We have a 1.4% hospitalization rate, and we have mobilized 315 COVID beds that are ready to respond, and we also have a R naught of less than 1%. And that's where I'll stop, Minister, and turn back over to you.
Okay. Thank you very much, PS. And our media partners and others online can field questions to get better particulars, but we are very willing, and we should post these numbers so that persons can review and query where necessary. We do believe that this should be a very transparent exercise. The public must know. And in fact, it's important that we balance the need for the public to operate within the protocols and framework of protecting themselves, the population at large, and the links between that and the cost to treat. The more we breach the rules, as some persons are, the home stay, home quarantine, the more you likely will get infected or spread to others, and the greater the cost as it relates to hospital care. And that's very important that that link be made. So we have to take a sort of holistic approach to delivering that message. I want to just spend 3 minutes or so to outline one of the critical components of my sectoral link to COVID, where we spoke about the need to develop a management plan or a plan to treat with COVID. And, we are moving into a phase now where we are moving from making as a primary effort using significant restrictions, keeping COVID out of Jamaica. Clearly, COVID is here. And there was value in significant restrictions to keep the virus out, the restrictions at our air and seaports, so that we could prepare ourselves to deal with it, because we felt it was inevitable, as it is the case with all other countries. Now that we are at a place where we think we have prepared our hospital infrastructure, we have over 350 or so COVID beds, we have gotten the ventilators in, we have trained staff where necessary. And the fact is, life also has to go on. We have diaspora members who have been out on vacation who need to come back in, others who have relatives here who depend on them, who have to come, business people who have businesses here and of course have to look about their business. We're a very open economy. And then finally, of course, the tourism interest, those who will come for rest and relaxation. The dynamics of managing the COVID risk has to be borne in mind in the context of easing of restrictions, not to mention internal restriction easing, people wanting now to go back to church or to wherever, work, etc. And so the ministry has been working on a plan in recognition of living with COVID and the risks that are associated with that. And we're going to be unveiling more details around that plan, but I did speak to it, outlining that living with COVID means, first and foremost, that we always have to be cautious. We cannot let our guard down. As I like to say in parochial terms, COVID's still a keep, and therefore people must not ever get complacent, despite the successes that we have had. But secondly, there are some specific things that we have to do and are doing contained in that plan. These include a review of the existing legislation to bring them in alignment with international health regulations, requirements, and the drafting of policies that support infection prevention and control measures at home, in the communities, and at the workplace. So it's a review of the process that clearly reinforces the general messaging that we have been pushing around physical distancing, wearing of masks, sanitizing, cleaning surfaces, and this is going to be the new standard operating procedure, the new normal that we like to call it. The Strategic and Human Resource Review of the Health Emergency Operations Center, EOC, we're here now at the physical space, to increase the capacity to respond to multiple and varied disasters and the documentation of EOC procedures. So we need to always be ready for a health emergency. It doesn't have to be COVID or COVID-like. It could be a hurricane, it could be a earthquake, it could be many other forms of emergencies, dengue or otherwise. And COVID is requiring us to upgrade and to review. Creation of some 2,208 posts for community health aides, significant addition of capacity, making existing health aid workers, community health aid workers who are temporary permanent, so they have security of tenure, adding another 1,000 to 1,200, which has started, and they are going to be the sort of army out in the community, monitoring, encouraging, teaching, motivating, handing out brochures, and bringing back information, intelligent information, as to what is happening that may represent a risk in a particular area. So targeting vulnerable groups, the old, those with comorbidities, hypertension, diabetes, helping them to go to their clinics, a range of things. These community health aides are going to be absolutely critical as we shift heavily into surveillance as opposed to just sort of testing. And surveillance will become the dominant feature of the approach. Another 500 posts for public health inspectors, again an important development, and training for contact tracers. A big part of our success has been those men and women who go out in the field to take the risk, to test people, to visit homes, and we're going to reinforce that. A review of the organizational structure of the medical officers of health in each parish with a view to enhance the capacity to respond to emergencies will be also an important part of that issue system. Critically also, part of the COVID plan or recovery plan from a public health perspective is the development of a national lab policy, including a system of licensing of labs and requirements for conformity to a national quality standard. So people say a lot, why we don't use the private labs to outsource testing? And I get that question every day, no matter how we respond to it. The truth is, private labs, as it relates to COVID, do not have the equipment, do not have the accreditation, and do not have the training to either collect the samples or to test. And so it is not that we want to do everything in the public space at the university or at the National Public Health Lab. It is because we are the only ones that are accredited to do it and the only ones with the machines to do it. Now, we need to play catch up, but better late than never. We need now to get our private labs engaged so that should an event like COVID reoccur, we can manage through collaboration with the private sector. And that has started. We started to train some members in the private space. Accreditation will take some time, but even if it's just for collecting of samples, that is going to be very possible. So that's going to be a very important part of the process. And finally, the approach will involve an assessment of the sea and airport protocols. So the idea around ensuring we have the protective gear, the training, if necessary, the expansion of staff, isolation rooms, all the gadgets that are required, because it is in the coming and the going of Jamaicans and non-Jamaicans that contagious diseases can spread. And so we need to review that process and enhance that process. So all contained will be part of a plan, which we will unveil in due course, that will represent the new norm, if you will, and over the next year or so, for however long COVID lasts as a threat, we will engage stakeholders to be a part of offering that solution. Okay, now I want to ask the Chief Medical Officer to comment briefly on a few of the issues that are taking place at our airports. We are aware that there have been some backlog, that persons have been waiting for test results. It's not something we can shy away from. There is a reason for that. The numbers have grown significantly, and as a consequence, we have had to make some adjustments. Those adjustments will be further done over time based on an assessment of the risk. But again, it's all part and parcel of the approach to gradually open up and to manage the opening up while balancing the risk, because opening up is going to have to be necessary to restore normality to our society and to Jamaicans and those who visit Jamaica. So we're aware of some of the conditions, sometimes chaotic conditions, and we're working to address those. I'm going to ask the CMO just to give a brief overview as to why this is the case, or could be the case, and the approach to screening, and why surveillance is absolutely critical as part of the new norm going forward. CMO.
Thank you, Minister. Good evening, everyone. First, I would just want to say that our surveillance protocols within country, first of all, started out with the identification of cases through persons presenting to health facilities with symptoms, and based on the case definition, them having met the criteria in terms of respiratory symptoms, fever, and with a travel history, would have been designated as a suspected case, and then would have been tested and found to be positive or negative. Positive cases lead to a case investigation, where we then identify the contacts of that person, and what we have been doing is testing those contacts, whether they have been symptomatic or asymptomatic. And we have found that we would have had positive cases in both the symptomatic persons as well as persons without symptoms. In addition to that, the next step that we had taken in terms of surveillance would have been to test all respiratory illnesses coming into our health facilities. And this included our primary care facilities as well as our secondary care facilities. So all fever, respiratory symptoms that looked like influenza-like illnesses, or more severe acute respiratory illnesses, or lower respiratory tract infections that were admitted to hospital, were all tested to find out if they could have had COVID. In addition to that, we have tested our healthcare workers, and we have looked at certain groups of persons that we consider to be high risk, such as our infirmary cases, where we thought that these were vulnerable groups, and we wanted to find out if there was anybody that was working in the infirmaries that was positive for COVID. And having done that, we found that there was one person out of the almost 1,000 persons that we tested. When we decided to reopen or lift some of the restrictions at the borders to allow persons to come in, a decision was taken to test all persons that were coming in. We started out with very few air flights coming in that returned some persons, and we tested those persons. When we moved on to returning our Jamaicans who were working on ships who needed to return, we tested all of those persons that were coming in. At that time, the numbers were small enough for us to handle. But however, as we moved to larger numbers, it became more and more demanding with large use of resources. We decided to reopen the borders to flights coming in by air in June, from June the 1st, first to Jamaicans, and then on June the 15th to tourists. At that time, a decision was taken that we would do a period of testing to determine what was the positive rate of those persons that were coming into the country. And several persons were picked up as being positive. We had about a 1.3% positive rate in the persons that were coming into country at that time. And most of these persons would have been tested that were asymptomatic. We had very few persons that were with symptoms. As time has gone by, however, and more restrictions have been lifted, then the volume of persons that are coming into country has become larger, more than we can manage to continue to do routine testing at the airports. We're not only faced with a problem in terms of the human resources to carry out the testing at the airports, we're also faced with capacity issues in terms of supplies, because as the number of cases grew worldwide, the demand by the manufacturers of these supplies, including swabs and testing reagents, it becomes harder for us to get the continued amount of supplies that we need to continue testing. So there are various issues that we have to contend with in terms of going forward with testing. Now that we have reached this point in the epidemic in Jamaica, it becomes even more important for us to be able to test persons that have symptoms within country, and not so much to focus on persons that are without symptoms that are coming in at our airports. So we have now stepped back a bit in terms of the testing at the airports, and we are now testing only some persons that are coming in at the airports. And this is to give us an idea of whether or not we continue to have positive cases coming into country. Over the last couple of days, maybe in the last 2 to 3 weeks, we have tested thousands of persons, and that has created a little bit of challenge in terms of returning the test results in a timely fashion. At the present time, we have results that are backing up 2 weeks, probably a little bit more than 2 weeks, and if we continue to test at the rate that we're testing, then that backlog will increase. Now, we are moving to clear that backlog as quickly as we can, but we do recognize that there are persons that are waiting for results. But what we want to emphasize to these persons that are waiting, we ask them to be patient in waiting for the result, but we also ask them that they remain at home for the 14 days quarantine period. And if they do develop symptoms, that they get in touch with the health department as quickly as possible. Because this is where we have to move towards in terms of monitoring persons that are coming into the country. The test that is done when they come in initially is a one-off view as to what is happening. But many persons are within that 14-day incubation period and will have negative tests. There's a false sense of security that because you've tested negative, you are now free to move around. However, any time within that first 14 days after an exposure, someone can become infected. And so therefore, the 14 days of observation is really what is key. And persons need to stay home. The family members, the community members must become aware and be alerted if they see persons outside who they know have just returned from countries and where they would have had an exposure to COVID-19. Everybody has to be vigilant. Every single Jamaican has to be vigilant to keep those persons at home for that 14 days. Because when you become symptomatic during that 14 days, that is when we will test you. We are moving away from testing persons at the airport when they come in. Right now, we continue to sample some of the flights in order for us to get an idea if there are positive cases that continue to come into the island. But persons will become positive during that 14 days, and so they must let us know if they develop symptoms. Minister, I think I would want to stop there and see if there are any questions.
Thank you very much, CMO. So there you have it, the summary for today. A discussion around budget, testing, airports. We did not say a lot around quarantining, which was billed as part of the discussions, but we continue to do where necessary. Institutional quarantining, but as you know, we have shifted a significant amount of the capacity towards home quarantining, and in the case of non-nationals, along the tourism corridor, persons who, of course, come for leisure remaining on property. Again, this is a very dynamic process. It's a process that has to be managed based on the realities of the circumstances, based on assessment of the risk, and based on what is practical and possible at a particular point in time. And where we are now as a country, as a people, 120 days or so after the first test results, first positive, we are at a stage now where we are watching the developments elsewhere. North America is inextricably linked to Jamaica's fortunes because we travel so much there and from there travel here. Managing the risk around that, both for locals and non-locals, while at the same time finding the best way to get persons to be safe while allowing them some additional freedoms, in this case, to travel back into their country. We could have decided to stop and not allow anybody to enter. Clearly, that would mean the virus would not come in, at least not now. But I'm sure when we open up, whether 6 months' time or otherwise, you would be faced with the same risk. So it's really a matter of managing the process. And there are risks involved, there's no doubt about it. Every decision has a corresponding risk. And it is a job of public health and the government to explain what those risks are with every decision. And that's what we're doing, while calling on all Jamaicans to play their role in managing that risk. All right, thank you very much. Stephen, over to you.
Thank you very much, Minister. We're going to invite our media colleagues on our Zoom link to use the raise hand feature to pose your questions to our head of entities. So we're going to go to Brittany Clark.
All right. Hello. Good evening, everyone. Are you hearing me?
Yes, go ahead, Brittany.
Okay. So with regard to surveillance, other than the JAM COVID-19 app, what other resources or technologies are being employed to ensure that the COVID-19 patients are adequately monitored? And what kind of systematic evaluation is being done around the different COVID-19 processes, that management, control, and surveillance, to ensure that we are still going along the right track and possibly ready for this anticipated second wave? Thank you.
All right. Thank you. Thank you for that question, Brittany. We have increased our capacity to monitor persons at home. What we have is a system now where persons, when they come in, they register on the JAM COVID app. There will be certain high-risk features in terms of your health, in terms of your home assessment, that, and of course where you're coming from, that would be indicated on the information that is collected. Now, when persons come into the airports and they download the app, what we're moving towards, and we're hoping that by the end of this week, this will be fully up, because we know that the personnel within the health departments are not able to manage hundreds of persons that are coming into the parishes. But what persons will be able to do now is that they will be able to go on the app and daily monitoring will be done. So they would be able to upload their temperatures and their symptoms. The health department will be able to monitor those, and one of the key features is that when there is an abnormal temperature or an abnormal symptom, then there will be an highlight. It will be alerted so that the persons that are monitoring the system will be able to pick that up and to be able to do an intervention, a face-to-face intervention, a call whatever is necessary that at that time. So in that way, we will be able to monitor a larger number of persons. In addition, the information that is collected in terms of high-risk persons, whether it is a high-risk home in terms of the assessment of the home, or whether it is a high-risk person in terms of health, in terms of having comorbid illnesses, or whether it is a person that is over the age of 65, then these persons will also be highlighted by the app, and these persons will be targeted for closer monitoring than just following up in terms of the information that is coming into the health department. So these persons will be targeted for visits and for checks to see if they're doing okay. And this is where our community health aides come in. We have engaged quite a number, over 1,000 community health aides, and they are presently, quite a bit of them are in training now. These persons will be out in the communities, and they will also be able to monitor the communities for persons that are coming in, who are visiting or who are returning to Jamaica, who may have health problems or may be in homes that have problems that can lead to outbreaks. So they will also be able to monitor there within the community as well. So we're putting in all of these measures so that we do not lose anything. We do not lose any information. As soon as somebody develops symptoms, we would be able to pick that up, to have them tested, and to have the appropriate intervention. And then also to be able to monitor to ensure that people are sticking to their quarantine orders.
Thank you very much. CMO, we're going to go to Jamaica Social.
Hi, good evening, guys. I'm Cassius Watson for Jamaica Social. Two questions. One to the CMO, and it's surrounding Florida, Dade County, Dade Miami County to be exact. Their infection rate is now at 26%, while I think overall the state is at 16%. State of Florida is that area now being flagged? I mean, we just last week we had our consul general from the area speaking, saying that Jamaicans were literally running out of town because they were a bit scared. Is Florida going to be? Is Florida and the local Miami Fort Lauderdale area? Is that more focus is now going to be on that location? Second question to the minister or to the permanent secretary, you could probably take this on, regarding there are doctors who have studied overseas, and minister, as you speak, it's more and more going to be more and more important for an all hands on deck approach, meaning that more medical personnel and support staff will be needed as the numbers grow, and as the prime minister says, 22 flights will be coming in just July alone, let alone August, September, when more flights will be coming in from and people from all over the world. You have some youngsters, some doctors who have studied in China, Cuba, and Russia, who are feel that they're being shortchanged and kind of being treated like bastard children compared to those who have studied at the University of the West Indies. They're being asked to do an extra exam, to get back in the system, and they really feel dejected. I've spoken to about 3 of them, and they want to know, how can you speed up this process so that they can be treated just like Jamaicans, and more so, they want to serve this country. How can they be brought in line and be sped up the process of them getting back into the Jamaica system? That's it.
Well, first of all, I'll answer the question with regards to Florida. Yes, we have flagged Florida as a location of high risk. You know that we are moving towards utilizing pre-testing as a screening method. And so persons that are coming from Florida will be required to do a pre-test. Persons have already started uploading that pre-test onto the Jam COVID site, where we're able to examine it and to see if we can validate that test. But starting on the 15th, it will be a requirement that persons will have that pre-test uploaded so that we can examine. In addition to that, we are also targeting flights from Florida coming in at both our airports for testing still. With regards to the process for persons to practice medicine within the country, as you know, we do have a medical council that is our professional body for physicians in Jamaica, and persons that are to be registered as medical doctors would need to register with the medical council. Every professional body in each country has its own sets of rules that govern who it is that practice, what it is that the appropriate course of study, and what it is that it recognizes as an appropriate course of study. It's just like for us who study medicine in Jamaica, we can't go to the United States and start practicing. We have to do an examination to be able to be able to practice there. So just as it's the same in Jamaica, there are certain medical schools that are recognized that the council has enough information about that they will be able to feel confident to be able to go ahead and to register these doctors. However, for universities that we do not have all of that information on, then an examination is required. So this is not an unusual practice within each jurisdiction, and so this has been the practice that we have had for years, that persons are required to sit the CAMC exams before they can be registered fully as doctors in Jamaica.
Thank you very much. Very much, CMO. We also had invited members of the public to submit their questions on Slido. And I just want to put two questions here. Somebody says, I'm planning to come to Jamaica on the 10th of August. If I take my test a few days prior to coming and it's negative, will I have to be on quarantine? The person is coming to Jamaica on the 10th. If they test negative, will they still have to quarantine?
Okay. So the rules that we have circulated does say that persons will still be required to do a health assessment. So if it is that you have a negative test, but you come into the airport symptomatic, you are picked up as having a fever or are noted to have any if you look ill, then of course you are going to be pulled out of the line for an additional health assessment and may require to be tested and possibly isolation. Now, if it is that the health assessment puts you at high risk for other reasons, then you may also be needed to be tested. But everybody that comes in, Jamaicans that are returning to the country, are going to be required to go into a 14-day quarantine period. For tourists that are coming into the country, they are going to be required to obey a stay-in zone order where they stay in the tourism resilient corridor. So there is a restriction order on all persons that come into the country, depending on which group that you fall in.
Thank you very much, CMO. And the second one, someone says, good job so far. Are we reconsidering a lockdown of entry from the US based on the alarming COVID numbers?
So that would be a policy decision. So let me take a strike at that. Every decision that we make, of course, the Prime Minister chairs the COVID subcommittee of Cabinet and, of course, the Cabinet. We all collectively take advice. Public health, of course, drives the advice, the clinical advice that is. And the advice from public health is founded in the risk assessment around each decision. So the restrictions on entry and specifically related to particular countries, and in the case of the US, to particular states, as is now in the case where some states are required pre-testing effective, I think the 15th, right? 15th of July, is based on the risk associated with those states. and by extension, the country. Whether or not there's a change from what is the case now is a function of whether that risk becomes more severe or increases or it decreases. If it remains the same, then chances are the status quo will remain. We do note that there are increases taking place in a number of states in the US, over 40 states, I think, and that does mean that the risk is intensifying. So it really is an issue of observing and continue to monitor, and if there is a requirement for pre-testing for the whole of the United States of America, then I don't believe the government will hesitate so to do based on that risk becoming justifying that particular action. So right now, it's a limited number of states, but the point I'm making is it could increase based on that risk profile, and we watch it every day. I mean, in public health, we monitor these things multiple times of day, every day, because we get the results on from the WHO. That's the number of positive cases. We have dedicated intelligence gathering platforms that we get information on, and I'm kept constantly abreast of these things. And of course, it is my duty to pass this on to the Prime Minister and my colleagues, and at that point, decisions are made. So it could change based on the risk.
Thank you very much, Minister. We're going to go to 18 degrees north.
Hello, good evening, Minister and CMO and Mr. Brian. This is Zara Burton. I have several questions for the CMO, and I would like to understand if maybe you could write down a couple, because I have, I think, 4 here. So the first one is, how were the COVID positive patients that we experienced here in Jamaica repatriated? Were they flown back on commercial airlines or private airlines? Were they flown in groups or in singular fashion? That's one. Second, has any tourist worker tested positive since June 15th? Third, what percentage of those coming into the country now will be tested at the airports? Because you said you were going to be sampling. Fourth, are tourists also waiting 14 days for test results? If they have to wait 14 days for test results, how are we furthering the protection of these tourist workers who must interact with those waiting?
Thank you for those questions, Zara. Very provocative questions. I'll try to answer as best as I can. First of all, what I need to emphasize that in going about our day-to-day business nowadays, we have to pretty much assume that everybody has COVID. And so therefore, how we operate within our business spaces, within our recreational spaces, within our homes, we have to take that into consideration. And that is what really living with COVID is about. The fact is that you cannot tell if somebody has COVID. You cannot tell if, they were symptomatic when they were coughing outside the door and they stepped in and they're not coughing now. You can't really tell if they were sitting at the table in front where you are now sitting and they have coughed all over or sneezed or anything and the droplets are on the table and you've touched it. So you really have to operate in a space now where you assume that persons have COVID and you always carry out your infection prevention and control measures. Now, in reopening of the tourism sector, one of the things that was done is the careful review of the protocols that were put out by the tourism ministry into how it is that tourism workers would operate within the hotel industry and within all the other areas that are associated with tourism. Now, and the main feature of these protocols was adhering to strict infection prevention and control measures. Now, it means that it is not business as usual. We're very open, friendly people, and we always try to make visitors feel very welcome to our country. But it really does mean a different way of operating. It means that the tourism workers have to wear masks, they have to maintain physical distancing, they have to pay a lot of attention to the cleaning of surfaces, ensuring that there is proper sanitization of spaces as persons move about within those spaces. Now, this is a part of how you operate within that business and decreasing the likelihood of your becoming infected. So it is, in terms of tourism worker protection, there is a lot of protocols that are there now. The tourism worker, they have a sensitization course that they have to undergo before they go back to work. They do a screening themselves, and then they have different measures that they have to carry out before they go into their workplaces each day. And the checks that are done in terms of health checks and temperature checks. So it's a continuing monitoring of the tourism worker and the adherence to the protocols that is really going to keep them safe and prevent them from becoming exposed and preventing, therefore, them from causing infections among their family members at home. Now, in terms of if we have had any tourism worker that have so far been infected with COVID, no, we don't have any positive cases of tourism workers presently, but we have had positive tourists within hotels, and we have had different measures that have been put in place based on where those persons are. So I know that in particular for one hotel, we have quite a few hotel workers that are home in quarantine because of possible exposure, and they have been tested, and we're waiting on those results. We have other situations where the guests have been isolated within the hotels, and a lot of precautions have been put in place for them to complete their isolation within that space. So a lot of things have been put in place to prevent the exposure of the hotel worker, but then also to be able to assess them and to have the appropriate intervention if there is any possibility of exposure.
I think it's important just to add that there are deviants in this mix. There are persons, whether tourists or non-Jamaicans, and in many cases Jamaicans, who have tried to find ways around the system by breaching the corridor or the home arrangement if they are a guest in a private home of a villa or a smaller unit. And we have had cases where we have had to pick up one or two persons. There's one case which I won't elaborate too much on, where we had to pick up the 3 or 4 persons and take them to institutional quarantine or own operated quarantine until they were able to board the next flight out of the country. We haven't exposed a lot of these things, but perhaps we need to or ought to send a clear message that we will not, where we have information, follow up on that information and take the strongest possible action. Again, we have locals who have tried to breach the stay-at-home or quarantine order by doing all sorts of things. I won't go into it because I don't want to advertise some of the things that are being done for fear that it may be incentive to others to do it. So you're always going to get that level of non-compliance, and it's unfortunate because one would assume that as Jamaicans or citizens of the world, we would appreciate the importance of managing this risk. But unfortunately, this is not always the case. So we have to be vigilant in our enforcement as much as we are in the public education to get going. And it's not a perfect system by any stretch, but I think it would be so much easier if persons who come in would comply with the rules. And we want to just emphasize that, again, the importance of that for all concerned.
In terms of the number of persons that are being tested at the airport now, we are testing probably about 30% of persons that come in. What we are doing is we are targeting the flights that are coming in from the high-risk the areas that we have designated as high-risk locations, and we're testing some flights from those areas. And this testing really is to give us an idea whether or not there is a continued flow of positive persons that are coming from these areas. But it really is the measures that persons operate within that is really going to protect them from becoming exposed and infected. You also asked about, says it was a tourist worker testing at the airport. You also asked about persons that have left the country. Our protocol is that once we have a person that is positive, that we would inform the airline. So a letter is sent to the airline to advise them that this person there is a no-fly order for this person. We don't state what is happening to the person, but that we advise them that they are unfit to fly. A negotiation usually takes place many times in terms of whether we place these persons in state facilities for quarantine or whether we can quarantine them, isolate them within whatever residence, hotel they were in previously. Many of the cases have actually, the hotel management have allowed for persons to continue their isolation within that space, taking the necessary precautions, and the health departments would visit to ensure that those precautions are in place. So we have had persons that have left on before the isolation period has been completed, and persons have been left by medical evacuation. Persons have left by private flights. We have had one or two persons that have actually left on commercial flights, and these persons would have left before their result was available. However, again, I emphasize that every entity now and every business that is operating now really should be putting the appropriate measures in place to ensure that infection prevention and control measures are in place. And so the wearing of masks, physical distancing, the use of hand sanitizers, hand washing, respiratory etiquette are all measures that are there to prevent the risk of exposure. I think I'll end here.
Thank you very much, CMO. Debbie Ann Wright had a question. She was asking, with the new testing approach, won't we miss many COVID-19 cases given that many persons have been asymptomatic so far?
Mm-hmm. We certainly will miss cases, and this is where the quarantine period is of importance. Okay, remember now that we have had cases, we've had 39 cases of local transmission prior to this, where we would not have been able to pick up where it is that those persons would have become infected. That infection came in to the country, started with somebody entering the country with COVID-19, probably asymptomatic, and may have passed it on to their relatives, their close contact, or they may have been symptomatic, not thinking that they had COVID, and have infected other persons. What we want is for persons, as soon as they develop symptoms, to report it, to isolate themselves and to report it. Fortunately, most of the cases are in fact asymptomatic. And what we have seen is that the level of spread from the asymptomatic case is very low. However, we still, we want to reiterate that it's really maintaining the quarantine order that is really going to keep us safe. That is what is going to keep you safe, your family safe, your community safe, and the country stay safe. You have to stay at your home and report your symptoms as soon as possible. That is the only way. Even if you had a test that was negative when you came in, if you became symptomatic after, you have to report it. The testing only gives us a one-off picture. It's the monitoring that is important. And the Ministry of Health and Wellness does not have enough people to monitor everybody, but we have enough Jamaicans who can monitor themselves and monitor their family and their friends. So every Jamaican has to become an officer for the Ministry of Health and Wellness with the charge to keep the country safe, to report persons when they are seen out on the road, when you know they have just come from abroad. You need to report them so that we can get, even if it needs that we have to get the security forces involved, but we have to ensure that people stay at home to keep the country safe.
Thank you very much, CMO. We're going to go to Emma Lewis.
Hi, good evening. Just two quick questions. One regarding testing. Can you, I gather that we'll be doing less testing in the future. I get that impression. But what is the real reason why we are doing less testing? Is it a shortage of human resources, or is it the actual testing kits and material, a shortage of that? And also, how is this going to impact the backlog, which is already very more than 2 weeks? Okay, and the second part is about recoveries. I'm hearing or reading a lot of stories that recoveries are actually taking much longer than anticipated, and that there are side effects and after effects. And would that is a 2 week? Okay, there's a 2 week quarantine, but are you taking these factors into account? And is this why the recovery rate seems to have slowed down a bit? I hope that makes sense.
Right. In terms of the testing, all the reasons that you've stated contribute to the reason why we will be testing less. But I really want to reiterate that we are not testing less in terms of testing suspected cases. Several weeks ago, the WHO Director General spoke about test. And what he said was test all suspected cases. Suspected cases are cases that meet the case definition. And we are not stepping back from that. We are ensuring that all persons that have respiratory symptoms or other symptoms suggestive of COVID-19 are tested. And we always want to maintain that we have that supply of testing reagents, testing kits, swabs, everything in country at all times to be able to manage those cases. So we are not cutting back from testing according to the surveillance protocols that we have in place, meaning testing all suspected cases, and testing all respiratory cases. And again, where we figure that we have particular groups that are of high risk, then we are also going to be testing those persons. So there will be no cutting back on the surveillance measures within country. And there will be no cutting back on the required testing for those. And we will always ensure that we have the capacity in country to manage that. What we are cutting back on is the wholesale testing of persons coming into the country who have no symptoms. And the reasons that we are cutting back on that, first of all, the reasons why we started to do that was to really to get a picture. Once we reopened or lifted the restrictions at the borders, we wanted to get a picture of what was coming into the country. And our intention was to do this for 2 weeks and to get an idea, to know where were our areas that we had risk and how many cases were coming in. So that we have achieved that objective in that we were able to say what was happening coming in at our ports of entry. But it was not our intention to continue to test persons that were coming in, especially knowing that the volume of persons were going to be increasing. When we started in June, we had 13,000 persons that were to come in. And we could have managed that, and we did test those persons. Over 95% of those persons were tested. When we look at July and we have over 50,000 persons coming in, continued testing would be at the risk of those resources that we need for surveillance protocols within country, surveillance protocols for suspected cases. We need to have those capacities, and we would put ourselves at risk. Not only at risk in terms of our human resources, because it does take a large volume of persons to be able to manage what we were doing at the airport, but we are in a global crisis. We're in a global crisis when it comes to supplies and testing reagents as well as swab sticks. Countries are finding it difficult to be able to supply the needs of especially the larger countries that are really mopping up the resources that are available worldwide. It becomes harder and harder for us to get these scarce resources, and therefore we must utilize these resources for the best management of this disease. We cannot afford to utilize our resources at the ports of entry, testing persons that have no symptoms, while it is that within country, if we have cases popping up, we're not able to manage our outbreaks. So the best utilization of resources, I would say, is the answer. The best answer to the question that you've asked into why less testing at the ports of entry. What is the other question?
My other question was about recoveries, and
Right.
has the recovery rate seems to have slowed a little bit, according to the numbers.
Right.
And are you aware of issues affecting recovering patients in terms of other side effects and
Right.
slow recovery rates?
Okay. So the recovery rate is going to slow because it's going to follow the curve in terms of the number of confirmed cases, but it's going to be about 2 weeks behind. So we would have had a peak of the number of cases in about the middle of April. So once that peak of persons started to recover, then we'd have a peak of recoveries. Since then, the number of confirmed cases have slowed down, and so subsequent to having that period of time when we were having a large number of recoveries, our numbers of recoveries would also slow down. I hope you understand what I'm saying. In terms of we do see all the literature, and we have our own experience in terms of the long time that it takes for persons to clear the virus from their system. What has been clear in terms of the worldwide, the studies and the reports that have been out there, it appears as if persons, even though they remain positive for long times, they are not infectious. And so the WHO has put out new guidance in terms of how it is that we discharge persons, the discharge criteria, looking more at a clinical criteria rather than a laboratory criteria for discharge. Because what in providing this guidance, the information that they looked at was that persons who were symptomatic were more likely to be spread disease for longer periods, and these persons were actively spreading for up to about 10 days. What they found is that persons who were asymptomatic were spreading for a shorter period. And so they have changed their discharge criteria to say that after 10 days of a confirmed positive, if the person have been asymptomatic for 3 days, that they would be can be considered recovered. We have been more cautious, and we have not gone down to the 10 days. We have maintained a 14-day period once a person has been asymptomatic for at least 3 days, and we do retesting for our cases that have been admitted to hospital. So we are being a little bit more cautious than the guidance that is out there, but our actions are based on the information that led to that new guidance.
Thank you very much, CMO, and thank you to the members of the media for their questions. And we thank also those on Slido who submitted their question. I'm going to ask Minister to give his closing remarks, but I'm going to ask one final question from Slido, which Minister is best to answer. Someone says, I see a lot of political campaigners in my community without masks. What will be the protocol with what seems to be an upcoming election?
Okay, so elections are constitutionally due, I think, February of 2021. So we do have some time. I don't call elections, so clearly I wouldn't want to venture to give an opinion on upcoming or not upcoming. But to the extent that any campaign, or frankly speaking, any activity involving multiple persons is to take place, whether it's in the church or at a bar, which is now allowed, the protocols would be very clear in the COVID period as to issues around infection prevention and control. Some of them are known, so the masks will be important. And, as a member of parliament, I go into my constituency, St. Catherine West Central, and I have my mask on hand. Difficult if you're having a soft drink with someone, or a not so soft drink for that matter. So you have to remove it, but you try to respect and to keep it on. And I do encourage my constituents so to do, and where I can afford it, I try to give them, distribute where they don't have. The physical distancing, so we it's hard because persons as Jamaicans are used to the touchy-feely type of approach. We are a friendly people for the most part. And so you have to encourage, and that would be a protocol that would be important. And of course, the sanitization. In fact, I've been visiting some institutions, whether it's a church or a school, or a shop or a bar, and I'm quite impressed with the fact that a number of them have put in place makeshift sanitizing stations, if you will. They just take a bucket, they punch a hole in it, put a little pipe onto the bucket. They have some hand washing, detergent or soap, and they elevate it on a stand, and they put a little handwritten piece of paper onto the bucket and say sanitize or wash your hands. And you don't need to be sophisticated to achieve the objective. Many have done that. I have seen it, and that is something that we should encourage. So the answer to your question is that any public gathering, whether campaigning or otherwise, would be required to stay with the protocols that we have established. And the ministry, of course, will guide that based on the risk assessment. Okay, so in closing, let me just thank my colleagues here around the table, the Permanent Secretary and the Chief Medical Officer, Stephen, head of PR at the ministry, and others who are here for another press briefing, digital press briefing. Thank those who have been listening online. thank those who are watching, and thank those who have asked follow-up questions. Again, this is an important approach from our perspective to get Jamaicans to always be in the know, because we think in being in the know, they are able to understand the importance of this issue, the unfolding events around this issue, and what they need to do to protect themselves, their families, and by extension, the country. We are still managing COVID. We have done well, but we are embarking on a new phase, less restrictions in some instances, particularly as it relates to our borders, or airports in particular. The need for protocols to be observed in home quarantining or stay at home as opposed to institutional quarantining. Greater focus on surveillance to monitor the environment and to require persons to follow the protocols, report to a medical facility if they are not well, isolate or quarantine as prescribed. The hotel industry and the need for persons to stick to the corridor, the property that they are assigned to or that they have purchased for holiday stay. And all of this means managing testing in a targeted way where we will always be there to test the high risk. But because of the numbers, many will not require that level of testing, but will require that level of screening, but will be required to follow through on the other levels because it is a holistic approach. So we will continue to drill that through down, and of course the enforcement will be there, and we'll have to sharpen that up. So thank you very much for listening until we meet and discuss again. We're speaking to you live from the Emergency Operating Center at the Ministry of Health and Wellness in New Kingston. And I'm told that you should look on your screen because there is a video which hopefully will help again to reinforce and support the message. Thank you.
Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry